Hi everybody, this is Marisa Cantu, and today I am presenting to you EJ. He is a 70-year-old Caucasian man presenting to the ER by ambulance with signs and symptoms of stroke. His history of present illness, EJ was accompanied by his daughter, who reported he had slurred speech, drooping facial expressions, and confusion and unstable balance when rising from the table. These signs and symptoms started at lunchtime, and the patient arrived at the ER within 180 minutes since the symptoms began. At the ER arrival, the slurred speech and facial drooping persisted. His blood pressure is elevated at 192/95, and he has tachycardia with a heart rate of 134 beats per minute. His weight is 170 pounds, his height is 5'8", his temperature is normal, and he denies any dysuria or incontinence. His past medical history is pertinent with hypertension, dyslipidemia. His status post-aortic tissue valve replacement for aortic regurgitation in 2012. He's had the winter blues the past year, and he's had feelings of a racing heart over the last year or so. His family history, his father died of an MI at 72 years. His mother died of a stroke at 65 years. His sister is alive at age 68 with hypertension, and his daughter and son are both alive, and they also have hypertension. His social history, he was a former smoker. He is a social drinker, approximately 1 drink per week. He's been widowed for 2 years. He eats healthy, except since he's been widowed, he eats a lot of canned and microwave meals. He does walk 20 to 30 minutes 5 days per week. He has no known drug allergies. His current medications are simvastatin 20 milligram once daily, aspirin 80 milligram once daily, hydrochlorothiazide 25 milligram once daily, lisinopril 5 milligram once daily, and St. John's wort 450 milligram 1 capsule daily. His estimated creatinine clearance is 93.7 mils per minute, and his BMI is 25.8 in the category range of overweight. His prioritized problem list is ischemic stroke, atrial fibrillation, elevated glucose, uncontrolled dyslipidemia, and signs and symptoms of depression. For assessment of disease, beginning with acute ischemic stroke, his neurological physical exam showed decreased alertness, drowsiness, spontaneous movement in his left extremities, but no movement in the upper right or lower extremity, even with deep pressure. He does not follow commands, and he nods his head inappropriately. An emergency CAT scan showed no evidence of acute intracerebral hemorrhage. He had an NIHSS score of 15, indicating moderate stroke. His carotid Doppler showed about 20% carotid stenosis, which is classified as small degree. So he does not meet criteria for carotid artery stenting or carotid endarterectomy, as indicated by the AHA/ASA stroke guidelines. He is on no current therapy or prophylaxis for stroke. He has uncontrolled atrial fibrillation and longstanding persistent AF, which is classified as greater than 12 months duration by the AHA, ACC, HRS, AFib guidelines. Longstanding persistent AF is likely a consequence of his aortic regurgitation, status post-tissue valve replacement, and also age-related. His EKG did note irregular rhythm and atrial fibrillation. He has 1+ pitting edema. He is on no current therapy, and further assessment in regards to drug selection after acute control. He does have moderate drug interaction with St. John's wort. It decreases beta blocker and simvastatin effectiveness. We will pursue rate control. The options are beta blockers, verapamil, or diltiazem over digoxin when heart failure is absent. We may use amiodarone if any of the agents just suggested are ineffective, not tolerated or otherwise contraindicated. IV beta blockers are more effective than IV calcium channel blockers for rate control and for conversion to sinus rhythm. Flecainide, propafenone, and dofetilide are oral formulations only, so those will not be used in the acute setting. He has serious drug interaction if we are to use amiodarone. It would also increase simvastatin exposure. And a serious drug interaction between dofetilide and hydrochlorothiazide, which would increase dofetilide exposure. We will also pursue anticoagulation prophylaxis. His CHAD-2 VASC score, AFib stroke risk score is 4 if we include the current stroke, and the score is 3 if we don't include this current acute stroke. However, it's either score, he's still at moderate to high risk for thromboembolism. So for plan, for the hypertension, before the intravenous TPA, we need to lower blood pressure if his systolic blood pressure is greater than 180 to 185, or his diastolic blood pressure is greater than 110, or mean arterial blood pressure is greater than 130. Then immediate rapid blood pressure lowering is recommended. The options are intravenous beta blockers, labetalol, nitropaced, or nicardipine. If his blood pressure remains elevated after one of these products, we can use sodium nitroprusside. However, we need to exercise caution with nitroglycerin or nitroprusside due to the potential increase in intracranial pressure. We also want to avoid too rapid blood pressure lowering, greater than 20% the mean arterial pressure in the first 24 hours, to avoid reduced cerebral blood flow as recommended by the AHA stroke guideline. Recombinant TPA is contraindicated then in persistent systolic blood pressure greater than 180 or diastolic pressure greater than 110. For ischemic stroke, recommend starting IV TPA 0.9 milligrams per kilogram over 1 hour with 10% of the total dose administered IV bolus over the first minute. Then the remainder of the dose is administered as IV infusion over 60 minutes. The maximum total dose is 90 milligrams in patients with symptom onset more than 3 hours but less than or equal to 4.5 hours, recommended by the chest antithrombotic and thrombolytic guideline for ischemic stroke. For our patient then, this would be a TPA 70 milligram over 1 hour total dose with 7 milligrams administered as IV bolus over the first minute, then 63 milligrams IV infusion over 1 hour. Our rationale or goal for TPA is to restore perfusion, minimize neurological impairment, reduce sequelae and long-term disability, and stroke-related mortality. For monitoring, after the TPA, we want to keep the systolic blood pressure less than 180 and diastolic pressure less than 105 as recommended by the AHA stroke guideline. A second CT scan is indicated within 24 hours of administration of TPA to assess for any intracerebral hemorrhage. For secondary stroke prevention, we can resume hypertension therapy in 24 hours as recommended by the AHA stroke guideline. Blood pressure target is individualized, however, we can aim for less than 140 over 90 based on ASH-ISH guideline. We want to optimize his lisinopril to 20 milligram and then up to 40 milligram daily as tolerated, as well as hydrochlorothiazide up to 50 milligram daily as tolerated. And I recommended to discontinue the simvastatin due to drug interactions and to switch to high-intensity atorvastatin, 40 to 80 milligrams daily as tolerated. For the valvular-associated atrial fibrillation acute control, I recommend starting IV labetalol, 20 milligrams IV bolus over 2 minutes, and then additional injections of 40 or 80 milligrams at 10-minute intervals up to 300 milligram total cumulative dose. If bolus dosing is not feasible or undesired, we can also do labetalol 2 milligrams per minute IV infusion initially, then titrate to a usual dosage of 50 to 200 milligrams IV infusion, again with the 300 milligram total cumulative dose max. Once stabilized, the patient may begin metoprolol succinate, extended release, 25 milligram orally daily. We may titrate weekly in 25 milligram increments based on response and tolerance. And for thromboembolism prevention, we can start apixaban 2.5 milligrams orally twice daily. This is the lowest end of the dosage range, unless we went to daily dosing. And this is reasonable to use for anticoagulation for 4 weeks after cardioversion based on ACC and AHA AFib guidelines. The rationale is to provide anticoagulation and less risk of major bleeding than dabigatran 150 milligram and the 110 milligram dosage. However, this is not in head-to-head trials. Monitoring for atrial fibrillations will be EKG continuously and daily until discharge or maintenance of normal sinus rhythm. Blood pressure immediately before beta blocker injection and at 5-minute intervals after each injection if using the bolus dose route. Obtain a TSH level and free T4 levels to assess any association to the AF. CBC, particularly electrolytes, including potassium, since he's on a thiazide, serum creatinine and renal function, and we also want to assess for diabetes since his blood sugar was elevated, and address his proteinuria. For thromboembolism prevention monitoring, we'll be watching for signs and symptoms of any blood loss and any new neurological impairment or signs and symptoms of CNS, such as a spinal or epidural hematoma, or any intracranial bleeding or intracerebral hemorrhage. After discharge, I'd like to follow up in 4 weeks to assess blood pressure, lipids, and anticoagulation efficacy and tolerance, and assess the patient's adherence. For non-pharmacologic therapy and patient education, discuss adherence to the new medication regimen for prevention of stroke and recurrent AFib episodes. Discontinue the St. John's wort permanently due to drug interactions. Avoid excessive canned food and microwave meals because they're high in sodium, which can increase blood pressure and fluid retention. For example, he could consider frozen vegetables instead of canned vegetables. Continue his daily walking regimen and begin monitoring his blood pressure at home every day. He could begin a healthy eating plan, such as the Mediterranean diet, with a goal BMI of less than 25. And also a follow-up evaluation for depression and patient education regarding social activities. And we also want to let him know to avoid grapefruit and grapefruit juice when he's taking his cholesterol medication. And that is my presentation. Thank you for listening. Bye.